My name is Matthew Kroll. I'm a PGY2 at Rush University Medical Center. My case involves a 60-year-old man with a history of uncontrolled diabetes type 2, hypertension, and hyperlipidemia who's presenting to the ED with 1 week of generalized fatigue and poor PO intake, as well as a 15-pound weight loss. He reports that he doesn't have any sort of weakness or any localizing symptoms, but he did admit to stopping his GLP-1 receptor antagonist and metformins 2 weeks prior to presentation due to GI upset. On arrival to the ED, he was hemodynamically stable. His physical exam was unremarkable. His BMP was significant for a sodium concentration of 116, as well as a glucose of 639. His serum ketones were elevated to 1.7 at the time. Even after correcting for the hyperglycemia, his serum sodium was still 129. Lipids were checked, and he was found to have a triglyceride level elevated to 11,530. He reported no family history of early MI or high triglyceride levels. The patient was not acidotic, and his lipase was only mildly elevated to 83. He was started on an insulin drip and admitted to the medical ICU. Endocrine was consulted for initiation of plasmapheresis. However, this was not started because the patient did not have any signs of pancreatitis, and high triglyceride levels alone are not reason enough to start plasmapheresis. He was started on the insulin drip and IV fluids, and his glucose stabilized after day 1. His ketones initially increased after treatment with insulin. This was due to the breakdown of triglycerides. The patient's lipase started uptrend as well. However, his serial abdominal exams remained to be benign. We were unable to get accurate sodium levels due to the high lipid levels in his blood serum. However, this was corrected by using a blood gas analyzer to measure the sodium. By hospital day 5, his triglycerides were decreased to 1,738, and he was transitioned to sub-Q insulin and transferred out of the ICU. So now, hypertriglyceridemia is a common phenomenon. It is estimated that 33% of all adults in the United States have it. However, only about 1.7% of adults have triglyceride levels greater than 500 mg per deciliter. The American Endocrine Society separates levels of triglyceridemia into mild, moderate, severe, and very severe, with the severe and very severe categories associated with a 5 and 20% lifetime risk of acute pancreatitis, respectively. Elevated triglyceride levels are associated with increased ASCVD risk. However, treating high triglyceride levels have not shown to be beneficial to ASCVD prevention. The main complication is acute pancreatitis. While triglycerides themselves are not toxic to the pancreas, the constant breakdown of triglycerides into fatty acids by pancreatic lipase is toxic to the pancreas. While our patient did not have pancreatitis, his lipase did start to rise from toxicity secondary to this triglyceride breakdown. The hypertriglyceridemia in our patient, who had no history of familial lipid disorders, was secondary to his insulin resistance. In a very simplified version, insulin will block the action of hormone-sensitive lipase, an enzyme in adipose tissue responsible for breaking down triglyceride and releasing triglycerides into the bloodstream as free fatty acids. The free fatty acids are brought to the liver and processed into VLDLs, which contain triglycerides, and these are distributed throughout the body. When insulin cannot tamp down this cycle, these increased levels of VLDLs, as well as their breakdown products, build up in the bloodstream and are measured as high triglyceride levels on lab tests. Finally, I briefly want to discuss laboratory measurement of serum sodium. The first ever method involves spraying serum over a flame to measure the output of light at sodium's wavelength. The current technique are direct and indirect iron-selective electrode potentiometry. They will measure the difference in millivolts between a standardized solution and a sample using an ion-selective electrode, which can measure one kind of ion at a time, such as sodium. Direct uses an undiluted serum and can directly measure ions, and is used mainly for blood gases. Indirect measurement relies on the fact that sodium only exists in the liquid component of the serum, and it also assumes that serum is 93% aqueous and 7% solid. When this assumption is wrong, such as when there's elevated lipids, sodium can look suppressed even if the concentration is normal. This case demonstrates an atypical presentation of hypertriglyceridemia without pancreatitis, as well as the biochemical pathways of hypertriglyceridemic pancreatitis and the importance of understanding how lab values are generated when interpreting data. Though his presentation was atypical, our quick recognition of lab error allowed our medical team to quickly triage and accurately treat this patient.